All right. Mark, do you need to do any recording?
We are recording now.
All right. So good morning. Case reviews for June. Thanks for making it either right now or video or recording later. So moving on, since we are a few minutes into 9 o'clock already. Oh, I'm gonna get an interruption here. Because text message. All right. So as always, this information that we present here is confidential and privileged. It has personal or identifying information in here that is protected against the HIPAA law, and that use and distribution or copying of it is strictly prohibited. So moving on to case 1. This is a case of a 60-year-old male. The chief complaint that dispatch called out for was chest pain, and PPE usage was appropriate depending on the time of our pandemic, but I think it was still appropriate. Anyways, the patient was alert. His airway was open and protecting. He was pink, warm, and diaphoretic. And there was no evidence of active bleeding. Initial vital signs were obtained shortly upon patient contact, with a heart rate of 128, a blood pressure of 194 over 125, a respiratory rate of 20, SATs of 94%. His GCS was 15, and he weighed about 120 kilos. His past medical history that he provided, to EMS was that he had a psychiatric illness. He was actually picked up at an adult foster home. He later told me that he was at an adult foster home because he had a TBI and that they make his decisions. He told EMS that he had chest pain that started 24 hours prior to their arrival, and it was at rest. They noted that he had left-sided chest pressure that he described also as sharp and stabbing, and that it radiated back into his back between his shoulder blades. He's told them that it was worse whenever he palpated it, but it was improved whenever he didn't palpate it or he was taking deep breaths. He had taken Tylenol, and he felt that there might be some relation to improvement of his pain with a shower. This call came in at approximately 6:09 p.m. Vital signs, as I mentioned earlier, and they got a couple 12 leads. In fact, 3 12 leads pretty early on, which I'm going to show you here. And these ones from the top down to bottom are in ascending order. So the initial EKG, it wasn't interpreted by the LifePak, but they noted that there was some abnormalities. There's sinus tachycardia, there's Q waves noted in the inferior leads, and then there what appears to be ST elevation that prompted them to get a couple more, which showed continued findings as mentioned earlier. And then let me see if there's anything else. And then there's potentially ST depression if you look at the lateral leads as well, more specifically the limb leads. And that on the third 12 lead obtainment, it actually had confirmed their suspicions with a read indicating sinus tachycardia, possible STEMI with inferior involvement, and ST depression noted in the lateral and the anteroseptal leads. So they gave him aspirin. They checked another 12 lead, which was essentially unchanged from that group of 12 leads, so I didn't put it up there. And then at 13 minutes, they got another set of vital signs, still tachycardic, still hypertensive, but better. They contacted online medical control to discuss. This wasn't a call with me, but one of my colleagues, and they wanted to bring him in as a STEMI. But after reviewing the Pulsera 12 lead, he didn't meet our specific criteria for STEMI. So they told him that, obviously if the patient clinically indicates to come in code 3, that bring them in, but we won't be activating the cath lab until we reassess the patient. So they got a blood glucose, which was 229, and they initiated transport at 17 minutes. He received a dose of nitroglycerin. Repeat vital signs showed improvement in his tachycardia, improvement in his hypertension, and on his second nitro, he started to get nauseated. Therefore, they gave him 8 of Zofran. They repeated that 12 lead just prior to arrival, which compared to the previous 3, it looks like that ST elevation in at least AVF is not as profound as well as lead 2. Lead 2 and AVF were more elevated in the earlier EKGs, and that was prior to getting nitro. He still has these ST depressions, though, noted. And they arrived to the hospital at 36 minutes. So in reviewing this case for this presentation, they were fast to get a 12 lead within a few minutes. They got many EKGs to confirm what they were seeing and making sure that it didn't resolve out, and also to kind of prove to themselves what they were seeing was real. They got vital signs, they got aspirin, they contacted online medical control because of the patient not meeting our strict criteria for a STEMI, but obviously concerning story and concerning EKG. And they spent less than 20 minutes on scene despite all of this care rendered. They got IV access. They took him to a designated cardiac receiving facility, and they got a SAT, which is part of our Clark County chest pain protocol, not our KPIs. And they got a more extensive presenting history than I typically get. Really, I had no areas for improvement. In the emergency room, his initial vital signs did show that he was still tachycardic. He was hypoxic, down to 92%, but his respiratory rate was normal. The 12 lead was obtained at the same time as a discussion with interventional cardiology based off of his pre-hospital 12 leads and his presenting self, I guess. He had said that he actually had intermittent chest pain 24 hours ago, but that it became constant that evening. And then he had contacted the staff at his adult foster home, which they promptly contacted 911. And that the additional history that I was able to obtain was that he had nicotine dependence, and he was clearly heavier. In the emergency room, he received fentanyl, heparin, Brilinta, and magnesium. His mag was a little bit low. And in speaking with cardiology, they came down after they reviewed the EKGs, and our discussion had said that his story was definitely concerning. They were concerned for a lesion that was impairing blood flow, and that unfortunately they had just accepted another patient to the cath lab who was just on the table at that point. So they didn't have availability to put him on in a timely fashion, and requested that he get transferred to a catheter lab capable hospital so that he can get intervention. So we arranged for him to get transferred to a manual. His initial labs at Peace Health were significant for a mildly low sodium of 130. His brain natriuretic peptide, which is a marker for potential heart failure, was elevated at 119, and his initial high sensitivity troponin was quite elevated at 5,613. To give you guys a little bit of a kind of an understanding, that our high sensitivity troponins, I believe the normal value, well, it should be not detectable, but under 20, I think is, if I remember correctly, is the value that usually doesn't flag, and that we do serial 12 lead or serial troponins to see if they're rising when they're detectable. So 5,000 is definitely quite elevated for us. At a manual, he was CAF. He had 100% inclusion of his mid RCA and his mid LAD, and he had significant stenosis of his bifurcation of his diagonal. They put in a drug-eluting stent to both his RCA and to his mid and distal RCA. And in regards to his LAD disease, they planned for a stage intervention. He was discharged on hospital day 3 to cardiac rehab. From what I can see, this case happened in April, late April, and it looks like he's still at the cardiac rehab, but nonetheless, he survived his STEMI. So I wanted to bring this case up because I thought that the crews really were astute to identify a concerning story, a concerning patient, and a concerning EKG. And although they knew that this patient didn't meet the straightforward criteria for STEMI activation. They contacted an online medical control to ask if we would activate it based off of what they had, but nonetheless to be ready for this patient as a potentially ischemic patient, actively ischemic with a lesion. So I wanted to talk a little bit more about acute coronary syndrome and a little bit more and how you identify concerning EKGs that aren't just ST elevation. So acute coronary syndrome is a rupture of a coronary plaque or a thrombotic event leading to ischemia or infarct. So the picture on the right gives you an idea of a little bit of a cartoon drawing of atherosclerosis, and as it builds up, it can it impairs flow, but it can occlude or prevent blood flow to the coronary muscle. And that a 12 lead can be normal for a few reasons. So, we look at our 12 leads as hang our hat on identifying somebody as having a legitimate problem, but they can have a legitimate problem and have a normal EKG for a few reasons. So there could be a small area that's impaired and we're not seeing it on the 12 lead. That area can be in a portion of the heart that's not represented by the EKG, so it could be in a silent area, or it could be a short duration. So either that there was a spasm and that spasm relaxed, and now that EKG now shows no evidence of ischemia, or that that thrombosis has moved its way and it's no longer occluding or preventing blood flow to that area. So that's another reminder of how important serial 12 leads are, especially when you have a concern for the patient. And then the added luxury for us in the hospital, if they've had care previously, is looking at old ones to compare. So ST elevation, there's obviously we talk about depression and ST elevation. Depending on where you look, you could say that ST elevation represents subendocardial injury and depression represents subepicardial injury, but it's not always true black and white as that. So we basically have agreed upon that ST elevation should equal complete coronary thrombosis, that it's including the blood flow. So that's why we look at ST elevation as such a um, an emergency, I guess you can kind of say, that's time sensitive and requires cath lab activation. So just like in the pre-hospital setting, in the hospital setting, we look at patients with chest pain or chest pain equivalent and look at them as, does this patient have an acute coronary syndrome? And then we try to divvy out the ones with ST elevation, go into the box on the right, where the patients that don't have ST elevation, are they in non-ST elevation MI, or are they just unstable angina? So the box on the right, the ST elevation acute coronary syndrome, are the ones that are need intervention and urgently, emergently, where the ones that are the STEMIs, they also need intervention, but not in the form of a cath lab. We can do timely medical treatment without having to activate the cath lab or to reperfuse that muscle, in the same sense of thrombolytics or a stent placement, or if that makes sense. So what parts of the EKG can be helpful besides just ST elevation? So this will be a bit of a review for some of you guys. Maybe there'll be some new information for you. So the picture on the right-hand side shows you a cross-section of the heart muscle. This part here being the most deep, or the inside of the heart, the endocardium, then the muscle, and then the epicardium, and then the pericardium. So T-wave inversion, T-waves are important to look at because they can be subtle findings that will indicate that this patient may be having impaired blood flow. So if the T-waves are hyperacute, and usually I've been taught that T-waves that are the same size as the P wave or as the QRS, I'm sorry, the QRS, or that just especially from old EKGs are more prominent, are considered hyperacute, and that could represent subendocardial ischemia. And then T-wave inversion would be representative of potential subepicardial ischemia. I don't particularly mind if you remember if it's subepicardial or subendocardial. It's more of that these could represent impaired blood flow and that they represent different parts of the heart. So T-wave inversion, I think we usually talk quite a bit about, but we don't talk about hyperacute T-waves. And that this is a kind of a demonstration here of what that would look like. So a normal EKG, the T wave is present, upright, but not quite the size as a QRS, where a hyperacute T wave that could represent ischemia of the subendocardial area is going to have, plug in for a second, is going to have a T wave that starts to reach the height of the QRS, and then T wave inversion would be usually negative deflection below the isoelectric line. ST segments, we spend a lot of time about talking ST elevation, also ST depression. And then reciprocal changes, we look for when there's ST, usually represents ST depression, in that it's only considered reciprocal if there's injury, transmural injury with ST elevation. So if you see ST depression and you don't see ST elevation, you should not consider this potentially ischemic unless it's a posterior MI. And then Q waves, not that the presence of Q waves, but the presence of pathological Q waves that represents dead muscle, dead cardiac muscle, and that usually a pathologic Q wave in regards to looking at leads representing the inferior and lateral parts of the heart is going to be at least 1 millimeter wide and at least 3 millimeters deep to be considered pathologic. Anybody have any questions on ischemia or ischemic findings? So going over our protocol, chest pain for the concern for acute coronary syndrome, universal precautions, we want to make sure that we get a SAT on our patients and that we are trying to obtain their SpO2 anywhere between 94 and 98%, so supplemental oxygen if they are below. Get a 12 lead. Our 12 lead is time dependent, so getting a 12 lead within the first 10 minutes of the patient encounter. 4 leads don't count, so 12 lead. If you have a chest pain or you're concerned for a cardiac patient, just put a 12 lead on, or document a 12 lead. Aspirin, unless it's contraindicated, I ask everybody that I'm giving it to, are you allergic to it? Are you actively vomiting or pooping blood? The other potential contraindications is going to be liver failure, and then checking for a systolic blood pressure. As long as it's not below 110, nitroglycerin can be administered, but there's areas to be cautious about, such as right-sided MIs and patients that are on Cialis. And you should try to get access prior to giving nitro. Fentanyl can be administered, and if they're hypotensive, you should be treating them as appropriately for our shock protocol. And then if you suspect an acute MI, you're going to be looking towards doing a STEMI early response protocol. Our protocol says that the chest pain has to be less than 12 hours. So this patient had 24 hours of chest pain. 12 lead should have ST elevation at least 1 millimeter or greater in at least 2 of the leads that we're looking at. So with this patient, they had ST elevation in 3 in AVF, but we're outside the 12 hours. They can't have a left bundle branch block or be in a paced rhythm unless there's concordance in 1 or more leads. You want to let the ED know about this patient so they can mobilize their staff appropriately and provide the care as you would for any other patient. Transport code 3, and if the initial 12 lead is negative or inconclusive, repeat it. We talked about the importance of serial EKGs. Yeah, and then if the 12 lead indicates inferior MI, do a V3, V4 to evaluate for right-sided. All right, any questions? Any comments before moving to the next case? Next case is a 15-year-old male. EMS was dispatched to a high school. They were dispatched to a collapsed patient. Her PPE usage was documented as just masks and gloves. The patient was unresponsive. His area was open, but he wasn't protecting it. He was pulseless. There's no active bleeding, and he was pale, cool, and moist. Those vital signs that were listed here were listed by fire after they got ROSC, and it sounds like the ROSC was pretty early on. No report of past medical history, so initially vital signs were zeros. And but they didn't document as zeros. HPI, or history of present illness, is that he was walking through the halls when he collapsed. He was noted to have what they thought was seizure activity. They've checked for a pulse. There wasn't one, so they initiated CPR and grabbed an AED. They shocked him. They, as in the staff at the school, shocked him twice, and that they had stated they did not know of him using any drugs or alcohol. And so fire was on scene prior to transporting the ambulance arrival, approximately 10 minutes. They started a line. They gave half a liter. They did CPR. They bagged him. They documented that they also were using an eye-gel, although that wasn't carried over in the other documentation, so that's why I don't have it in there. And then he also gave him 300 milligrams of amio, 1 milligram of epi, and they shocked him 3 times because he was in VFib and escalating doses of 200, 300, and 360. The time frame was a little bit confusing, but what I believe happened was that he was shocked twice by bystanders. Then he was shocked 2 times by fire, and on the 2-minute pulse check, he had ROSC. So I don't really know where the 3rd shock went in there, but we documented 3 shocks. So, and then the rest of the time is based off of the transporting ambulances timeline. So at 3 minutes, they checked a blood glucose. And just so you know, what I told you about the time frame of shock was based off of fire, which had more details of the resuscitation prior to the transporting agency's arrival. So the rest of the boxes on the right are going to be from the transporting agency. So after ROSC was achieved, the patient was moaning, groaning, and pulling away. So restraints were placed on the patient's extremities. They initiated transport at 9 minutes after their arrival, and their first set of vital signs were a pulse of 98, blood pressure 89/70, a respiratory rate of 24, and a GCS of 8. His end-tidal CO2 was 7, and because he was still agitated and impairing his ability to be ventilated through the eye gel was removed, and he was given 140 milligrams of ketamine. At that point, they decided that they should move towards RSI, so they gave him his succinylcholine per their documentation, and they had indicated that they were RSIing him because of agitation and concern for aspiration. They suctioned him, and they used video laryngoscopy. They documented that they intubated him on the 2nd attempt, and a little bit of the 2 charts stated that the reason why they didn't get the first one was because the tube was too big. So it was a 7.0 initially, a 6.5, and then the 6.0 is based off of, I guess the tube was pulled some point during the transport, and that the fire agency had to intubate the patient. So it was a 3rd attempt, not documented. That was a 6.0. So he got 50 micrograms of fentanyl after intubation. Repeat set of vital signs shows improvement in his blood pressure, 128/95. And he got another dose of fentanyl 6 minutes after the first dose for post-intubation sedation, and after arrival, 1 minute, he got 10 of Versed. So this patient, I thought that looking at the care here, he had early CPR and defibrillation from bystanders, but also from fire. Appropriate ACLS meds were given to this patient. Blood glucose was checked. They got a lot of access on the patient, 3 IVs, in that because of the coordinated care for all of the providers, both lay people and our EMS folks, that would probably contributed to his ROSC. Rooms for improvement was a bit confusing for documentation, but trying to look at both and gain this timeline, it looks like we didn't document all of our procedures, including the IGEL and the third intubation attempt, as well as not documenting the time for ROSC, which is helpful for us to know how long he's been down from based off of the phone call that you guys received, and then how quickly did we get ROSC after that. There's no 12 lead obtained, at least documented, post ROSC. And remember that treatment for agitation doesn't include ketamine. For this patient, I would not recommend Haldol. I would recommend Versed, especially since you've got a post cardiac arrest patient. That ketamine we should not be using for agitation of any sort. In that, don't forget to document all of your attempts for intubation. It's going to be good for us to be able to look at our stats as accurate. So the follow-up, this patient had gone to Randall's, so I think it was Randall's, but it wasn't Peace Health. So if Dr. Mock is on this call, feel free to add any additional information. But I have a limited amount, which is he had a dilated cardiomyopathy. His echocardiogram showed that he had an EF of 30%. His hospital team thought that he had actually catecholaminergic polymorphic ventricular tachycardia. An AICD was placed, and that his beta blockers were increased because he had still runs of VTAC despite his beta blockers. In that during his hospitalization, he also had a non-inclusive thrombus in his IVC, so they were considering starting a hypercoagulable workup. In that during, or at least what was relayed to me, is that he was grossly neurologically intact, besides some short-term memory loss from his cardiac arrest. And that interestingly, that he has a family history. His maternal cousin has a variant of a desmoplakin gene, but she didn't know what the clinical significance was, but maybe contributing to why he had this catecholaminergic polymorphic VTAC. So a little bit about this condition. This is marked by episodes of syncope that can occur with either physical activity or extreme emotional state. It's an inherited syndrome or inherited disease. Usually it's self-limiting. The VTAC resolves and they wake up, or they no longer feel dizzy, but this can be sustained and leading to degeneration of that VTAC into VFib, which sounds like what happened for this kid. The causes of fast ventricular tachycardia, in that the mean onset is 7 to 12 years for them to present with like a syncopal episode or cardiac arrest, but the data had shown that there have been cases up into the 4th decade of life that they present with their first time episode. And then the diagnosis is going to be looking at an echocardiogram and a 12-lead EKG. Those will be normal, essentially. EKG will be normal, the heart will look normal, and that they'll be able to induce VTAC with either exertion or extreme emotional state again, and that there could be a diagnosis based off of inheritance, so heterozygous pathogenic variant. Management, the mainstay, at least initially, is beta blockers and avoidance of any inciting events. So what I was finding was that they avoid any physical activity or extreme exercise to try to prevent a reoccurrence of this VTAC, in that they can also do a left cardiac sympathetic denervation. If those fail, they move towards ICD. That's just off of an article. It looks like this kid got an AICD based off of his initial presentation with a cardiac arrest. Mortality is that left untreated, 30% of these patients will have a cardiac arrest, and up to 80% will have at least one, if not many, syncopal episodes. So it gives you kind of food for thought for your young person that you come in contact with that had either a near syncopal or syncopal episode. Obviously, context will be important, but this is a condition, one of the many conditions that could be potentially life-threatening in a young person who suffers a syncopal episode. So our protocols, just a review here, is going to be looking at cardiac arrest, VFib, and pulseless VTAC. We're going to shock them, do CPR, assess their rhythm, and defibrillate them if they're in a shockable rhythm again. Our agents of drugs of choice would be amiodarone, and if amiodarone is contraindicated, lidocaine. If we think that it's torsades or multifocal wide complex tachycardia, it would be MAG, and you're going to reassess the rhythm, defibrillate, initiate CPR, and then our drugs for epi come later. So that'll be your second line epi as a reminder for everybody. If the patient is requiring multiple shocks, you may want to change the vector or the position of the pads and resume CPR. You have the possibility of giving another 150 of amio or lidocaine if amiodarone is contraindicated, and kind of continue this process. Contact online medical control. I would say if you're at the fourth or fifth shock, I would probably contact online medical control to ask if there was any other considerations that needed to be done, or potentially if this patient would be a person that would benefit from going to the hospital without ROSC, but that would be someone I would have a conversation with online medical control with first. This patient, although he was 16, I don't think I saw the weight on him. Essentially, I assumed that he'd be an adult weight. So although there's a section on pediatric patients, if the pediatric patient is adult weight, we would treat them at adult doses. And then under notes and precautions over here on the right-hand side, you want to address the airway without interrupting CPR. It's totally appropriate to place an iGel because it's quick and fast and it allows them to be ventilated. Make sure you're not over breathing them. So 8 to 10. And bicarb is not recommended for routine cardiac arrest sequences, but should be given in TCA overdoses or patients with hyperkalemia or suspected hyperkalemia. And remember, IVIO should be above the diaphragm. And yeah, here it says fifth shock. So although I said fourth or fifth, our protocols say fifth. Any questions? Moving on to case 3. Case 3 is of a 31-year-old female that was found down. EMS was called for an unresponsive patient, possibly an overdose. PPE usage was appropriate. The patient was found unresponsive. Her airway was open. She wasn't protecting. She did have spontaneous respirations. She had a pulse. Vital signs were obtained shortly after arrival with a heart rate of 117, a blood pressure of 84/62, respiratory rate of 10, GCS of 3, SATs of 99%, unable to obtain past medical history. Partially because it wasn't available, and it looks like partially because there was a language barrier. And her history of present illness was that family had seen her 30 minutes prior acting normally, and that they'd state that she was under a lot of stress recently. They believed that she might have had a suicide attempt, and they suspected it was off of sleeping pills, but they weren't able to elaborate what sleeping pills that she might have taken. They had reported no history of drug or alcohol use, and initially upon EMS arrival, law enforcement was doing CPR. So once EMS identified that the patient had a pulse and was breathing, CPR was discontinued. This occurred at midnight 5, so The patient had a blood glucose checked at 3 minutes, which was 124. An IV was established. She started to vomit. They noted that when they were assessing her, her eyes were twitching, so they thought she might be having seizure activity, so they gave her 5 of Versed. At 12 minutes, another set of vital signs were obtained. Heart rate now is 140, blood pressure is 115 over 86. Her respiratories are 10, her GCS is 3, and her end tidal is 59. They were pre-oxygenating her, thinking that now that she has demonstrated some emesis and she had a low GCS, that she likely would be intubated, and they got a 12 lead. So looking at this 12 lead, it's fast, it's wide. Being 31 years old, I wouldn't necessarily think that this was BTAC, but obviously an abnormal EKG, not her baseline, potentially related to the substance that she had used, and it looks like she's got a left bundle. They RSI'd her with 160 milligrams of ketamine and 120 milligrams of succinylcholine. Intubated her on the first try with direct laryngoscopy and bougie. At 18 minutes, another set of vital signs were obtained, noted to have continued tachycardia 128, hypotension 71 over 37 with a MAP of 48, respiratory rate bagged was 14, her GCS was still 3, and her end tidal was improving down to 51. They initiated transport at 19 minutes. They started treating her for post-intubation sedation with 50 of fentanyl. A second IV was established and she was given some fluids, presumably for her hypotension, but not substantial. She got 200 cc's during the 3 minutes before hospital arrival. They repeated her EKG, which showed a continued tachycardia, continued wide complex, but of note, her previous 12 lead showed a QRS duration of 0.12 seconds. This one shows 0.14 seconds. So widening QRS. And I wanted to go back here. So they said in their documentation that they did recognize that she had a wide complex and tall T waves, but they didn't have the time to intervene. But they relayed that information directly to the physician on handoff report. So in reviewing this case, I thought the great things that we were able to do was get in a blood glucose early instead of forgetting it in the setting of a potential overdose. Serial vital signs, neurologically assessing this patient, recognizing what they thought was potentially seizure activity, decision to RSI to protect her airway, and prepping her appropriately. They initiated post-intubation sedation with fentanyl, and they were able to get a 12 lead, in fact, a couple 12 leads. Where I think that we can do better is that if we have complexities on scene, don't forget to document that. So if you can't speak to them in language that you're able to communicate, then I would say documentation should include that there is a language barrier. Apparently, there was a suicide note that was found by family while EMS was on scene. So document that this was a suicide attempt with a suicide note found. And then if you have a patient who's hypotensive or you think there's potentially electrolyte abnormality, if that's hyperkalemia or you've got widening QRSs for you, then manage that early, because just like our hypoglycemic patients, we don't want to wait till we get to the hospital. We want to be able to intervene and start treating them earlier than later. So although the patient did get a little bit of fluids, make sure that they're on pressure bags, ensuring that she's adequately rehydrated with a low threshold to consider pressors. And then etomidate may be less arrhythmogenic than ketamine for induction. So in the emergency room, she arrived in cardiac arrest. She was in a PEA arrest. The treating physician treated her with Narcan and sodium bicarb. We've talked a lot about Narcan not being appropriate in cardiac arrest. I still hold by that. The bicarb probably in the CPR probably led to her ROSC on the next pulse check. Her labs were significantly deranged. She had a acidosis with a pH of 6.8. Her lactate was 16.5. Normal lactate's usually below 2. Her anion gap was 22. Normally that's below 10. Potassium was substantially low at 2. Normal range is 3.5 to 5. And her sodium was elevated at 150. Her EKG was repeated and now shows sinus tachycardia with a wide QRS. She now has what more morphology looking like a right bundle branch block, and her QRS now is 0.16. Remember, it was 0.12 when she first had her EKG. Poison control was contacted. They stated that if her QRS was unchanged on serial EKGs, that the bicarb would probably be more helpful for her acidosis than for like a TCA overdose, because at that point they still didn't know what she ingested. She was persistently hypotensive. She received IV fluid boluses. She ended up getting norepi. The central line was placed so they could give her intralipids. She was admitted to the ICU. She was cooled, and the husband was able to report that she actually had ingested Benadryl, 50 milligram unknown quantities. And then on hospital day 2, she was extubated. During her hospitalization, she saw psychiatry. They felt that she was no longer at high risk for suicide, so they discharged her home on hospital day 4. Just the first EKG from in the ED, and then the second EKG during her hospitalization. So drastic change of what her normal baseline EKG is in the setting of a Benadryl overdose. So good time to talk a little bit about Benadryl. It's a first generation antihistamine. It's an anticholinergic and it has sedative properties. Its kinetics for toxicology is that it can lead to tachycardia and widening of the QRS. It can block the potassium channels in the heart, leading to QTC prolongation and T-wave flattening, so they can look like torsades and they'll be treated with magnesium. And that this drug is lipophilic and it has a large volume of distribution within the body. Depending on how much of an ingestion they had, their presentation would be mild or moderate, would be more like anticholinergic effects. So dry as a bone, mad as a hatter, blind as a bat, those kind of toxidrome. And then severe presentation for overdose would be seizures, delirium, hypotension, and cardiac arrhythmias. Treatment, there's no antidote for this, but care is supportive. So if they're having seizures, benzos, if you want to manage your anticholinesterase, you can give physostigmine. If they're having arrhythmias, sodium bicarb. Some of these patients might get on VA ECMO if they're still hypotensive and crashing, and that some studies show that there might be utility with using intralipids, which is what we have in the hospital potentially for them. So our protocol, I thought this would be a good chance to review for overdoses, is that our Benadryl overdoses and our tricyclic overdoses are managed similarly. They're going to get bicarb. So if they're tachycardic, greater than 110, they have a dysrhythmia, they have a widening QRS, or if they have seizures, which this patient was tachycardic, she had a widening QRS, and they had presumably a seizure, is manage them with bicarb. So 1 milliequivalent per kilogram, slow IV push. And then the percent would be for seizures. And if you felt that this patient was having a widening QRS from that component that I was mentioning with the potassium channel inhibitants, that they may also benefit from magnesium. Any questions, thoughts, concerns before moving to the next case? All right. Case 4 is of a 16-year-old male. This is a picture of, I think it's Molten Falls Bridge. So the call was for an injury from Molten Falls. So this kid had jumped off the bridge into the water feature. PPE usage was appropriate. The primary survey is that this patient was awake. His airway was open and he was protecting it. His pulse was present. His skin was pink, warm, and dry, and he had no active bleeding. Vital signs were obtained shortly upon arrival. He had a tachycardia at a rate of 110. He was tachypnic at 25. SATs were not obtained, but this was because there was an extrication issue. And his GCS was 15. His past medical history included depression. This was not reportedly a suicide attempt, and he also had DeGeorge syndrome. Just as a reminder, DeGeorge syndrome is a congenital syndrome where there's a microdeletion on the long arm of the chromosome 22. It can manifest as congenital heart defects, facial feature abnormalities, as well as learning and developmental problems. This patient was later on described to have a cognition level of a 5th grader. So he had jumped off this bridge. He landed in a seated position in the water, but did not go deep enough down to hit the ground, reportedly. And Sean, I think that you had said that this was presumably a 40-foot fall because it was dry. I don't know if he can answer, but anyways, the patient immediately developed back pain. He did not lose consciousness. He didn't have any movement of his feet, but he was able to swim back using just his upper extremities. And they found him in the rock feature underneath the bridge. So it took about 40 minutes to extricate this patient with a raft and a litter. The vital signs I mentioned previously, and another set of vital signs were obtained 26 minutes later. Heart rate of 106, blood pressure 153 over 81, respiratory rate of 25, and SATs of 100%, still GCS of 15. At 27 minutes, they initiated transport. IV was missed, but they were able to obtain an IV 1 minute later. Blood glucose was 322. Physical exam was that the patient had lower lumbar spine pain and that he had an over-exaggeration to sensation to his lower extremities. He had no movement of his left lower extremity and a slight movement of the toe on his right lower extremity. Spinal precautions were initiated initially from patient contact as soon as they were able to be maximally provided. He received 50 micrograms of fentanyl for pain, and vital signs were repeated again. His tachycardia is improving. His blood pressure has decreased a little bit to 148 over 90, and he was activated as a modified trauma to Peace Health. Subsequent vital signs obtained again, showing improvement, and he got another dose of fentanyl before arrival at the hospital, 59 minutes. So in reviewing this case, I thought that the care was great. It documented the reasons for not having less than 20 or 10-minute scene time. They documented CMS and a neurological exam, and they repeated vital signs to trend his improvement or his response to treatment. There's a little section in their documentation that it said that they ranged his neck, but I think that that was probably an auto-generated response. In the emergency room, he had pan scan imaging, which revealed an unstable T12 3-column fracture. There was retropulsion, meaning that the fracture fragment had gone back into the spinal canal, so it led to severe spinal stenosis. Neurosurgery took him to the operating room emergently for decompression and stabilization. He ended up developing neurogenic bladder, so a Foley catheter was placed. He was discharged on hospital day 12. He was documented to be able to walk with a walker and transfer, and his diagnosis, besides his T12 fractures, incomplete paraplegia. So great care, unfortunate circumstance, but leads me to talk a little bit about do all trauma patients need to have spinal precautions? And I bring this up because there was a case recently that got us discussing this a little bit. So I would say that if it's clinically indicated, right, for spinal precautions. So if you've got blunt trauma, car accident, fall from a bridge, fall from standing, thinners, old person, they likely they should, and especially if they meet our modified or full trauma. If it's blunt trauma meeting modified or full trauma protocol, or full or modified parameters, they should be longboard, spinally immobilized. If they have penetrating trauma, they shouldn't unless they have midline neck or back pain, or they have findings to suggest that there's a spinal cord injury, weakness, loss of sensation of their extremities. This came up because there was an isolated injury to a wrist due to sheet metal that came in as a modified trauma, and that the patient was immobilized. And the belief was that all trauma patients, despite if they are a modified full trauma, whatever the conditions, as long as they meet modified or full trauma, they have to be immobilized. And that isn't true. It's only for blunt traumas or patients that clinically need it because of midline neck or back pain or compromise to suggest that this is related to a spinal cord injury. So review of our spinal immobilization protocol. Patients should be appropriate. They're blunt trauma with a altered level of consciousness, midline pain or tenderness of their spine. They have neurological complaints. There's anatomical deformity. And if they meet high energy mechanism, which usually is our full and modified trauma patients. So if they are unable to be communicated with because you have a language barrier, or they're under the influence of drugs or alcohol, or they have a significant distracting injury, would be another reason to immobilize them. And then if you want to look over here on the right-hand side of the screen under C, this speaks specifically to our blunt trauma and our trauma system activation. She should have at least a cervical collar if you're not able to do a full backward. And then going back to the 16-year-old who had fallen off of a bridge or jumped off of a bridge, reminder that children under the age that are 15 years young or younger that meet our full or modified trauma criteria would go to a manual or Dornbecker unless they are at risk of cardiac arrest, you can't get access, you have an airway that you're dealing with that needs to be controlled, or if they don't meet any trauma criteria, they can come to our hospital. But if they meet trauma criteria, it has to be 16 years or older unless there's an emergent issue going on that needs to be stabilized at Peace Health. And then the criteria, I'm going to briefly go over. So GCS less than 14, hypotension, respiratory ranges that are deranged, any penetrating injury to the head, neck, torso, or extremities, proximal to the elbow or knee, flail chest, 2 or more long bone fractures, mangled extremity, amputation proximal to the wrist or the ankle, pelvic fractures, skull fractures, and then high mechanism of energy, such as 20 feet for adults or 2 times the height of the child, and then car crashes that are high risk, anticoagulation and trauma. And I'll let you guys look at the rest on your own. Any questions now about this case or any of the other ones? I haven't been able to look at the chat, so if there is questions, I'm not seeing it. All right. So just a review slide. The importance of serial 12 leads. I'm going to see if I can. No, I can't. Well, hopefully you can see this. This is 2 different EKGs. So this initial EKG up here shows just ever so slight ST elevation. And sorry, looking here as I'm trying to, so ever so slight ST elevation in leads 1 and ABL. This is patient had a atypical presentation for chest pain, and when they repeated the EKG, same patient, same encounter, clearly the EKG now shows ST elevation, both in 1 and ABL, but also in V2 through V6. So the importance of 12 lead EKGs serially, even if the story doesn't sound all that impressive, Second image here is to review the catecholaminergic polymorphic ventricular tachycardia. Usually presents in children or teenagers, can be single episode or first-time cardiac arrest. Benadryl overdoses can be considered to be managed similarly to sodium bicarb. TCA overdoses with sodium bicarb, MAG, and if they're having a seizure, Versed, and jumping off of anything can be harmful, especially if it's 2 times the height of yourself. All right, that's my references. That's all I have for you guys. Thank you.
Thanks, Dr. Gedwa.